All right, so we want to give a very special thanks to all of our event sponsors, especially the following platinum and gold sponsors for making this event possible. We couldn't do this without you, so thank you very much to the Iowa Department of Public Health, University of Iowa Holden Comprehensive Cancer Center, and Iowa Oncology Society, as well as everyone else up on that slide. Today's sessions are going to be focused on radon testing and mitigation as a form of cancer prevention. So we're really excited about that today. A few reminders before we get started. So you can see up on the screen what the continuing education credits are today. So nursing has been approved overall for 7.25 contact hours. Today's sessions are for 0.83. So if you have any questions, email Kelly Rollins and her email is on there. And then for CHES, overall 7.75 entry-level hours are offered throughout the week, and today's is 1.33. And again, Kelly Rollins is the person to speak to if you have any questions. Let's see, we ask, so after this portion where we got to see your beautiful faces, we ask that all participants turn off their video and mute your sound during the presentations. There will be a question and answer time after each presentation, and you're more than welcome to like raise your hand or hop on video or microphone to ask questions. Let's see. So sessions will be recorded and made available upon completion of the event on our website. Let's see, and just a final reminder, make sure that you're on mute. And I want to welcome Iowa Cancer Consortium Board member, Dr. Tammy Swenson, to introduce our first speaker. Welcome, Dr. Swenson.
Thanks, Liz. Good afternoon. My name is Tammy Swenson, and I am an assistant professor at Des Moines University. And I'm very happy to be your moderator today with our focus on radon, radon policy, radon-related cancers. Our first speaker this afternoon is Dr. Bill Field. Dr. Field has been actively involved in radon-related research for over 30 years. He's a professor at the University of Iowa's College of Public Health with appointments in the Department of Occupational and Environmental Health and the Department of Epidemiology. He received a PhD in preventive medicine from the College of Medicine at the University of Iowa. Dr. Field was the lead author of the seminal Iowa Radon Lung Cancer Epidemiological Study and has been actively involved in both the North American and global radon epidemiological pooling efforts. In 2009, his keynote address at the International Radon Meetings launched the World Health Organization's Handbook on Indoor Radon, a Public Health Perspective, on behalf of the WHO International Radon Project. Between 2010 and 2018, Dr. Field served as a member of the US EPA's Science Advisory Board. He currently serves as a presidential appointee on the Centers for Disease Control's Advisory Board on Radiation and Worker Health. In 2012, Dr. Field was the recipient of the University of Iowa's Michael J. Brody Award for his long-term public health commitment to the community, state, region, and nation. In 2017, he received the Iowa Cancer Champion Award. Dr. Field is a fellow in the American College of Epidemiology. Everyone, please welcome Dr. Field.
Oh, thank you very much for that kind introduction. And it's so nice to be with you, and it's really nice to see so many faces and names of folks that I know that are tuning in today. And I just thank you for tuning in today and having an interest in radon. So over the next 45 minutes or so, I'd like to talk about a little bit broader agenda than what we originally had for following the sessions. Participants will be able to do that. I'll focus heavily on those, but I wanted to expand it just a bit more, talk about radon occurrence, so sort of a reminder about Iowa, biological risk, information we have from the minor-based epidemiology studies, talk a bit about the residential studies, one of which was performed in Iowa, and then talk about occupational exposures and guidelines, and then just briefly touch on outreach at the end. So again, it's great to be with you. One of the things I say in some talks, as statisticians and epidemiologists, folks that work in epidemiology that deal with a lot of numbers, we throw these numbers out there, but just a reminder to myself and to others that when we talk about these statistics, pretty much everyone knows that's tuning in, listening to this webinar, it's not numbers. Each of those numbers have a person behind it. This is a quote from a colleague of mine that's passed away, that was an asbestos researcher. And he said, statistics are people with the tears wiped away. And I think as people that work with a large amount of data, when we're presenting it to the public, it's good to keep that in mind, that we're not just talking about numbers. Each number has a person behind it and loved ones. So as most of the folks know on the webinar today, the leading cause of cancer for men is prostate cancer, and the leading cause of cancer for women is breast cancer. But when we look at overall mortality, lung cancer is the leading cause of mortality for both men and women. And what's really impressive is you look at 22% for men and 22% for women. If you look at the next three leading causes of cancer, they pretty much add up to the first one. So what's really important to note is that for lung cancer, even secondary causes of lung cancer are extremely important when you compare it to the overall cancer burden that we have in the United States. Just some general reminders. The EPA's action level for radon is 4 picocuries per liter. It's not a health-based guideline. I'll talk a little bit more about that in the future. We're actually having discussions, should this action level be reduced, pros and cons of that. The average indoor concentration in the United States is about 1.3, and the average outdoor concentration in the United States is about 0.4 picocuries per liter. Radon is one of the most extensively studied carcinogens that we have, that and cigarette smoking. As early as 1556, Agricola described problems with miners working in mines and their lung-related diseases. And then you can see up through the 20s, first review of mining-related cancers, the 50s. And then something happened around this time here that really increased public awareness about radon. And then you can see after that event happened, there were a lot of really concerted efforts to increase our knowledge about radon health risk. And this is a little cartoon, not a funny cartoon, but a cartoon to show that this is this family outside your home. This was in the Washington Post in February 1986, and they can't go in their home because of the radiation in their home. And what that cartoon was about this family called the Watrous family, who lived in eastern Pennsylvania. And this is Stanley Watrous. He was a worker at the Limerick nuclear power plant, and he was one of the folks building the power plant, putting in construction. And one day he walked in at the power plant, and he left that day, and they had just installed the portal monitors to monitor radiation on workers. But what's important to note is at this point, there was no fissionable material in the plant. There were no radioactive materials. But when he walked out, he set off the detectors at the portal monitor. And he thought, that was really strange. Maybe some glitch with the monitors. The next day, he came in, before he went in the plant, he walked through and he set them off again. And what they found was that his home in Pennsylvania had thousands and thousands of picocuries per liter from radon in his home. And he had only lived there, him and his family had only lived there a few months. And you can see what Mr. Watrous said. I just thank God that if anyone was going to have a radon concentration that high, it was me, someone that would be able to detect that their problem existed, rather than someone living there that didn't know, that would live there for, say, 10, 20 years and receive such high doses. Even this week, I've received calls for that same area where people have radon concentrations of 1,000 picocuries or so in their homes, you can imagine. So really hot area as far as radon goes. So just a reminder, radon comes to break down the uranium-238 to radium-226, very long half-lives, to radon, which is a gas, and it makes its way into the home. It's naturally occurring outdoors. We used to say radon's naturally occurring, but it's not so much naturally occurring indoors. It's from natural sources, but the way we build homes increases the radon concentrations in the home. So it's an enhanced form of natural radiation in the home. We build homes in a way that captures radon. We can build homes that are radon resistant, just like we build homes now that don't have lead paint. We just choose not to do so. Fortunately, in some places in Iowa, like Iowa City and Carville, there's requirements in place now that if you build a home, you have to put in a radon resistant new construction features. You can't see it or smell it. And I always say if it was purple or some color or had an odor that came up, people would fix it just because they have a sensory reminder that there's this exposure that's occurring to them. For people that put continuous radon monitors in their house, and this is something mitigators used to do, they used to say, hey, just put this monitor in your house that would tell you all the time what the radon concentrations, and their sales went up so much because the homeowners had that sensory reminder that radon was present. As far as how it gets in the home, and I'll be showing some tables, and the tables come from a publication that we put together called Reducing Risk from Radon. It was funded by the EPA through a contract with Council of Radiation Control Program Directors, and we try to update it every 2 years. But this is, and at the end I'll have a link for this. But this is somewhat of a typical home where we live. You can have a crawl space, you have a basement, and radon gas makes its way up through the cracks in the foundation into the basement or through the crawl space. If you have forced air heat and you have your blower down here, it can blow radon up into the upper levels of your home and increase the radon concentrations. In Iowa, 98% of the radon in the homes that we have come from ground sources. They come from the ground soils surrounding the substructure of a home, or if a home is built on a pad, the radon comes from underneath the pad into the home. In some states, radon can also be high in groundwater, and as the groundwater comes into the home, the radon off gases. The risk is not so much from ingestion, the risk is really from the radon becoming airborne in the house and causing increased exposure to the respiratory epithelium. In some countries, there can be some concerns with building materials as well that will off-gas radon. If you look at a general map, and this is the old EPA's map, and fortunately now we have more environmental health tracking, and the CDC is working on an updated map based on more recent measurements that will hopefully be available and more detailed in the future that can be used. But this was back from the 80s. This is the map the EPA generated. And this is the map of the EPA radon zones. And when they first did estimates of radon, they didn't expect radon to be high at all in Iowa, because when they did the original estimates for radon in the United States came from what was called the NURI data, National Uranium Reconnaissance Expedition, where planes flew across the United States and looked at the uranium concentrations in each state. So they just crisscrossed over the United States. We don't have very high concentrations of uranium-238 in Iowa. In fact, it was pretty low, and EPA was shocked when they found out that 70% of the homes were over 4. And unlike through the Reading Prong, where natural uranium deposits are the source of the radon in those areas, in Iowa, our radon comes from glaciation that occurred millions of years ago, where the rocks from the Canadian Shield were sheared and deposited in Iowa. And it's not that there's that much uranium in the rocks, it's just that if you can imagine, you take this big boulder that's sitting on the Canadian Shield up in the mountains, and you pulverize it into small pieces. You have so much surface area generated that our soils from the glacial deposits have a lot of radon emanating potential. So it gives off radon. So we have the highest average radon concentrations, but we don't have the high highs like I was talking about in Pennsylvania, where they can have 1,000 or so picocuries per liter in just a small number of homes. We also did, as part of the Iowa Radon Lung Cancer Study, an outdoor survey of Iowa. And the darker colors here are higher outdoor concentrations. The number on top is becquerels per cubic meter. And then the bottom is picocuries per liter, which picocuries per liter that we're all more familiar with. And if you recall, I had mentioned before that the average indoor radon concentration in the United States is 1.3 picocuries per liter. So this is a little isoplate of outdoor radon concentrations. And you can see there's places in Iowa outdoors where we have concentrations outdoors that are equivalent to the national indoor radon concentration. So we have high exposures indoors, but we also have elevated exposures outdoors and indoors. So radon's a real problem in Iowa. The EPA estimated that we had a radon concentration outdoors of 0.6 picocuries per liter. And where that came from was when they did the outdoor surveys, they placed one detector in each state, and the detector in Iowa was placed at the hygiene lab at the University of Iowa. So you can see here, there is differences throughout the state when we did the mapping of outdoor concentrations. What's really important to understand about radon, and when we developed health guidance for healthcare professionals to help them teach their patients about radon, this is one of the facts that a lot of the healthcare providers weren't aware of, that the actual lung cancer from radon is not from radon itself, it's from the radon decay products. So radon itself, the gas, causes very few lung cancers, but as radon decays, it decays into a series of radioactive decay products. Some attach to dust particles, some stay unattached, and you breathe these dust particles in, and these radon decay products are solid. They stick to your respiratory epithelium, continue to produce alpha particles that can damage the DNA. So it's important to remember that the radon health risk is really from the radon decay products. If we could get rid of all the decay products, it wouldn't really matter too much what the radon gas is in the home, if we could filter out all these decay products. And that's what some big industries are trying to do that aren't able to reduce the radon concentration. You're just filtering the decay products out. So as radon decays, it produces a series of solid particles. And over on this side is the half-life. In other words, this is how long, half the time for half of it to undergo radioactive decay and not be there anymore. And each of these are solid little decay products that gets the whole way down to lead-210 with a longer half-life. And then finally it ends up as a stable solid particle, lead-206. But two of these decay products, polonium-218 and polonium-214, deliver the majority of the dose to the bronchial epithelium. These are alpha particles that deposit in the respiratory epithelium. Their half-life is not long, and some of the precursors have a little bit longer half-life. But once these are in there, they'll continue to decay. It'd be one thing if you just have one exposure, but usually we're at home, so we're getting chronic dosing of these radon decay products being deposited in our lungs. So the alpha particle is really a helium nucleus. So it's really a huge particle when it's right next to our respiratory epithelium. And it does a couple of things. When we get bombarded with these alpha particles, it can cause double-strand DNA breaks. One of the unique aspects of alpha particles is they cause a high number of double-strand breaks compared to other carcinogens, lung carcinogens that cause single-strand breaks. These cells then can die, or they can be repaired, or they can be misrepaired, and that's what can initiate the cancer. Lung cancer from radon is considered monoclonal. It starts with one cell, so there's not any threshold that we know of for radon-induced lung cancer. The other thing, other than double and single strand breaks that alpha particles can cause, are free radical formation. And these free radicals can cause damage to the DNA as well, cause single strand DNA breaks and other damage to the cell. And one of the interesting aspects of the study that we published a good while ago now, there's a certain, we all have different genetics. And some folks have the specific gene GSTM1, others don't. And on the webinar here, about 50% of the people listening in do not have GSTM1. And we found that people that don't have GSTM1, they're at much greater risk, threefold increased risk of developing radon-induced lung cancer, as well as smoking-induced cancer. So this is just one little gene. If you think about how we all vary and all the other genes that may confer risk that varies among the population. But what this little gene does is produces antioxidants. So the antioxidants counteract some of the free radicals that give us some protection. Just want to show you, because it's very abstract a lot of times when we talk about alpha particles and beta particles. This is a long-term radon test kit. It's called an alpha track detector. And these are placed in your homes for 3 months up to a year. And the radon goes through this little filter, decays, and then it goes produces radon decay products, goes through additional decay. But what's inside this little alpha track is this little piece of plastic. It's called CR39 plastic. And what happens is, as decays occur, the alpha particles hit the plastic inside the detector. And then you can take this detector after its exposure period, etch it overnight in acid, and then at 100x, at 100x, look at the number of tracks per time that the detector was in the home, and that's how they calculate what the radon exposure was in that home. But I just want to impress upon you, these are actual little pits put in this little piece of plastic from the alpha particles. Now, the plastic has been etched, but these particles or the etching won't show these unless these alpha particles cause this damage to the plastic. So you can imagine if it can do this to the plastic, what it can do to your bronchial epithelium. Another important aspect to consider is our overall radiation exposure. Radon's responsible for about 37% of the average individual's radiation exposure year after year after year. In Iowa, that's well over 50% for folks in Iowa, over half of our radiation exposure each year. But if you looked at this chart 20 years before, you wouldn't see these big categories. There's been just a huge increase in CT exposure for people, as well as nuclear medicine and interventional fluoroscopy. And these are all good, but what happens is you're getting more exposure from appropriate use of medical x-rays, but you're also getting that which causes gene instability, genomic instability. And on top of that, you're getting the radon exposure. So radiation exposure is cumulative. So since we're getting more exposure from these other sources, the radon exposure even imparts more risk since we're having an overall greater exposure than we did, say, 20, 30 years ago before the use of CTs. So there were two primary sources of epidemiology studies that led to our understanding of the risk posed by radon. There were retrospective cohort studies, and these were studies of radon-exposed miners that worked in underground mines. And for them, you identify the cohort. So you identify a cohort of miners, and then you follow them over the next 30, 40 years. In fact, many of these cohorts are still being followed, looking at the outcomes of the workers that worked in the mine. And then you look for what diseases occurred in this population. The other way to study radon risk is look through case control studies, the residential studies that I'll talk about. For the case control studies, you identify individuals with the disease, lung cancer, for the radon studies, and then you match them to controls that don't have lung cancer, and then you look at the radon concentrations in the cases, people with lung cancer, and in the controls, people without lung cancer. And that's how you come up with a risk estimate. So it's called an odds ratio of risk. And then you compare the exposures for cases and controls. So I'll just talk briefly about studies of underground miners. Studies of underground miners have been done all over the world, as you can see here. So these are all different types of miners: hard rock miners, uranium miners. And the unit of exposure, not important to memorize this or anything, but unit of exposure they use for the miner studies is working level. And working level is a cumulative exposure. One working level equals 200 picocuries per liter, assuming a certain equilibrium. And a working level month is that working level exposure. So exposure of 200 picocuries per liter for 12 months gives you 12 working level months per year. But that's what they use for these studies. Another sort of information I think it's worth knowing about. We talked about the EPA's action level is 4 picocuries per liter. And just about everywhere outside the United States, everyone else uses becquerels per cubic meter. So 1 picocurie per liter equals 37 becquerels per cubic meter. So you can see here the EPA's action level is 4 picocuries per liter. The WHO guidance or reference value was 2.7 picocuries per liter. US homes average about 1.3. And then there's 37 becquerels per 1 picocurie per liter, and 1 becquerel is 1 decay per second per meter cubed. What's important to note is this EPA's action level of 4 picocuries per liter. If the EPA would have said, we're going to treat and we're going to control radon like we control all the other environmental carcinogens that we control, so pesticides, chemicals, everything that they generally control at the risk is 1 cancer in 100,000 people. If we use that criteria for radon, we would have to reduce this level to not what you see outside 0.4, but to 0.04. So we would have to reduce outdoor air if we treated radon like we treat other environmental carcinogens that are regulated by the EPA. So you can see that this certainly is not a health-based guideline. So for the minor studies, there were studies done in all these different countries. Here's the number of lung cancers. And this is about 20 years ago. These numbers have increased greatly. Person years of exposure, a lot of working level month exposures here. Average duration of exposure is about 6 years. And this is just sort of a dose response. This is relative risk on the y-axis, and this is increasing exposure on the x-axis in working level months. And the red line would indicate if you lived in a home for, say, most of your life at 20 picocuries per liter, this would be the equivalent exposure you would have compared to the minor data, compared to the minors exposures. So you can see on, for many of these, the exposures for minors are much greater than what you would get in a lifetime in your home at 20 picocuries per liter for a lot of these different studies. But you can see a clear dose response for the minor studies. In other words, as there was additional cumulative exposure to radon, the risk estimates increase, relative risk substantially increases. So this is the Czech survey. You can see the same kind of dose response. Colorado, the Ontario one's interesting because there's a lot of overlap between what you could find in your home, which is what those minors were exposed to, see the same dose response. Newfoundland, very high exposures. Beaver Lodge, you can see that there's very much overlap between what you could see in your home and the findings from that study. And Radium Hill, tremendous amount of overlap. So what you have from these kind of studies is you have this kind of information and you project these risk estimates at higher exposures to what you may find in the home. So it's really an interpolation getting back to what, okay, so if it's linear response, what kind of exposure would we get in a home and what the risk would be? Is that's how the National Academy of Science first came up with the 18,600 lung cancer deaths per year in the United States. And it was a very excellent report written back over 20 years ago called Health Effects Exposure to Radon BR6. And the National Academy of Science estimated that through around 18,600 lung cancer deaths each year in the United States, that was their central risk estimate. The EPA, a few years later, updated this information based on 1995 demographics, and that's where the 21,000 came from, was an update that was performed by the EPA, took the National Academy of Science information, and the central estimate they came up with was about 21,000, or about 14% of lung cancer deaths were radon related. Now the percent in Iowa, we think is a lot higher as far as the attributable risk. And we estimate about 400 people or so die of radon-induced lung cancer in Iowa each year. So as you can see, this hasn't been updated since 2003. Just this coming week, and this is a webinar that's open to the public, it's National Academy of Science is reviewing whether or not there should be an update of this report. So there's a lot of good presentations here. I'm talking about, is there a need to update the BR6? And there's definitely a need to update BR6. So the hope is that we can update the information that we know for radon and come up with more accurate risk estimates. My anticipation would be that there's smoking's decreased. There's a synergism between smoking and radon, so that would reduce the number of radon-induced lung cancers. Unfortunately, the number of people exposed is much higher than it was in 1995. So my guess is the number wouldn't change much. But there's a lot we don't know about radon. More and more studies are coming out suggesting that there may be other adverse outcomes that are related to radon other than just lung cancer. We were just funded, a colleague of mine at Columbia University, we were just funded by NIH to do a 5-year study looking at radon and stroke. We put a grant in looking at radon dementia. There's very strong evidence there could be an association between radon and COPD, but right now the only one that's firm enough to say there is an association is lung cancer. So this is information here for this event. You can just sign up, no cost to attend this, but be very detailed information that will be presented next week. So if you look at overall risk estimates, so for the exposure at 4 picocuries per liter for a never smoker, the chance of getting lung cancer is about 7 in 1,000 for living in a home over your lifetime at that concentration. For smokers, because of the synergism between radon and cigarette smoking, the risk goes up higher. So you can see for these 7 in 1,000 or 62 in 1,000, if you recall back what I said about the EPA, how they regulate carcinogens, they regulate at the chance of 1 in 100,000. So you can see these exposures or these risk estimates at the EPA's action level 4, they're pretty high risk at an action level. So any action that you can take to reduce radon concentration, EPA acknowledges there's risk below 4. In fact, it's likely that over half the radon-induced lung cancer are occurring below 4 picocuries per liter because the population is so large being exposed at those concentrations below 4. So if you compare radon treated as its own disease category, if you look at, these are the 1920 mortality data, estimated US deaths. If you look at lung cancer and bronchus, as we talked, is number 1, and then these other types of cancer. But if you would treat radon-induced lung cancer as its own disease category, it would be one of the top 10 causes of cancer mortality in the United States. Another interesting information I think it's worth knowing is that if you look at the number of deaths each year from people that never smoked, and developed lung cancer, that's about 20,000 people. So lung cancer in never smokers is also one of the top 10 causes of lung cancer mortality if you would look at it as its own disease category. So like I said before, this is such a big risk, radon or smoking and lung cancer, so many deaths that even secondary causes cause major concern, but often the risk posed by radon is perceived as lower because the risk is so high for smoking. So people often say, radon is not a big risk. Well, yeah, not compared to smoking, but compared to other environmental exposures, radon is probably our leading environmental cause of cancer mortality. The leading cause of cancer, environmental cause of cancer, is sunlight, but as far as mortality, it's probably radon. So talk briefly about residential studies and why these are important. Is there's differences between the mine and the home environment. Miners are breathing heavier, the attachment's different to the aerosols in mines. There's diesel fumes in mines, and very few of the miners were females. And it helps to demonstrate the lung cancer risk directly. There's been 22 individual radon studies. None of those were included in the initial beer study when they looked at risk estimates. So these case control studies, these are actually studies of people living in their home. You look at the radon concentrations for the cases compared to the radon concentrations for the controls to come up with the risk estimates. We've had 7 studies in North America, 13 in Europe, and we pooled these studies. And a pooling is a little bit different. You may have heard of a meta-analysis. A pool study is where you take all the individual data and you reanalyze the data. So we did this for the Europeans did it, and we did it for the North American data. And if you look at the individual studies, this is the odds ratio. So an odds ratio of 1 is no increased risk. And the little black boxes, that X is the central risk estimates for all the radon case control studies. And this would be a 1.5 would be a 50% increased risk. And this is, remember, this is at 4 picocuries per liter. So you can see most of the studies have a positive increase, showing an increased risk. Now, some of them with a confidence interval, they're not statistically significant, but the chances of this many studies being positive is like less than 1 in 1,000. So we saw this data and we thought it was be useful to pull the data. And when we pull the data, you can see we're seeing these kinds of risk estimates for the pooled data. So for the North American, and now this is a 3 picocuries per liter, we're estimating there's a 10 to 18% lung cancer risk. And the Europeans estimated about a 16% increased lung cancer risk at 3 picocuries per liter. So this is, as we noted before, is below the EPA's action level. And because of exposure misclassification, these numbers are probably a bit low. As exposure misclassification increases, it sort of attenuates the risk estimates toward no association. So these are probably a bit low, and that's what we'd have to look at in the next round if we do a next beer version. So this is a graph from 20 years ago that Jay Lubin, a colleague at NCI, put together. So this is the different North American studies. That's the risk. So we have on the x-axis here, radon concentration, odds ratio. So a 2 would be 100% increased risk. So this is from the North American pooled studies. This is from the Chinese pooled studies. And as you can see, as the radon concentration increases, the risk estimates increase. This is from the European studies. And the big purple here one, that's the estimates from the pooled, or from the pooled minor data that was done. So you can see there's good agreement In epidemiology, we look at agreement between studies as an indicator of causality, as well as a dose-response relationship. So we see both here. So I just want to talk briefly about or occupational exposures. This is a study we did a while back in Missouri, had much lower radon concentrations we have here. So we put indoor radon concentrations in an individual's home, and these are all people pretty much that worked at county extension agencies. So you can see we had 83 in the home, and then they put, most of them put one in their workplace, so we have 81 in the workplace, and this is sort of a breakdown of what their workplaces are. And the county offices or the extension agencies, then there's some retail and some service. So here's the percent. Remember, 140 becquerels per cubic meters for picocuries per liter equivalent. You can see the percent for home and workplaces is pretty much the same. Now these concentrations are not in the basement. This is actually up on the first floor where the people are working. If we looked at the radon concentrations in the basements of the homes and in the workplaces, they were double. The percent was double what was over the 4 picocuries per liter. So you can see, even in county extension agencies in Missouri, there's a lot of equivalency between what you find in homes and what you find in workplaces. Now, some workplaces that have big volumes, you may have lower concentrations of radon just because of the dilution and depends on air exchange rates and others. But these are just typical county extension agencies that you would think would be a more health conscious group. But there's so many different occupations where you can have increased risk. Mine workers, contaminated waste sites, radon contractors and testers, employees of natural caves. I get a lot of calls each year from people that worked in caves over 2 or 3 years that they never tested it. Phosphate plant workers, oil refinery workers. So there's a lot of naturally occurring radioactive materials with that enhanced. Utility tunnel workers. I work with a couple of cities. One city gave radon test kits to test their radon in the utility tunnels, and the industrial hygienist that did it was fired after he wanted to report the findings. They never would allow the findings to be reported. So we don't know how high some of these utility tunnels are where the workers work. Folks work in subway, construction, excavators, power plant workers. Radon health mines. There's still health mines out in Wyoming and Colorado where people go and they sit in enhanced radon. Europe, it's really big. There's spas, balneotherapy spas where people sit in high concentrations of radon within the water. They think it's some therapeutic response. And it's really kind of interesting is that some of the noble gases have been used in the past as anesthesia. So you just wonder, these high doses, is there some sort of anesthetic effect that they're getting from the noble gases? This is kind of interesting. Water plant operators, you can imagine water coming in with high radon from the wells. Water plant operators, fish hatchery attendants. You don't even have to have high concentrations of radon in the water. There's so much water being used and it's totally aerated for the fish that the radon escapes. Employees who come in contact with technologically enhanced incidental exposure from almost any occupation. This is the biggest group at risk. Farming related activities. If you're downwind where someone's plowing, the plowing aerates the soil, which increases the emanation from radon. But this is the big one here, incidental exposure. And if we look at what the current Osha guidelines is for radon, and this is OSHA's, if you're working in a workplace, say a retail store or a bank, or like in Missouri where I showed the extension agencies, they would be covered under OSHA. This is an article I wrote a short while ago. This OSHA guideline back in 1987 was recommended to be reduced to below 1 working level month, and they thought that may not be low enough. Back in 87, the federal agencies were suggested that the concentration should be lower. So Department of Energy workers, it's 4 working levels per month. The Nuclear Regulatory Commission, people working in reactors, is 4 working level months. Mine Safety Health Administration, these are the underground miners, 4 working level months. So what OSHA is saying is that it's okay for someone working in a bank to be exposed to 3 times more radon than what someone that works in a mines. That's the current guidelines with OSHA. And if you look at the equivalency, so OSHA says it's okay to work at 100 picocuries per liter every day of the year And depending on what the equilibrium ratios between the radon and the decay products, this can go up to 200 picocuries per liter. So this is what's our current regulations are for people working in businesses. And this has been one of my real efforts lately, is trying to get NIOSH and these other agencies, get NIOSH to push these other agencies to help reduce these current regulations. And these are the legal regulations. Fortunately, a lot of people use the EPA guidelines for work-related exposures. This is many-fold higher than even the highest country outside the United States, 10-fold higher, this current limit. So this is something that really needs to be addressed. So in summary, radon's a global public health concern. We have direct evidence now that wasn't included in beer. That's a major health concern. I consider it our leading environmental cause of cancer mortality, and OSHA guidelines obviously need a lot of update. Because of the residential radon studies that I talked about, World Health Organization said they really needed to take more action on radon. So they developed an international radon project about 10 years ago that has a lot of good information on health effects. And what this guidance was for member countries to develop their own radon infrastructure and guidelines within their specific member countries. And they used the 100, right here, the 100 becquerels per cubic meters recommended, the 2.7. But for whatever reason, the chosen level should not exceed 300. So most of the workplaces in Europe can't exceed 8 picocuries per liter. So you can see what I showed you for the OSHA, they're saying 100. So even most countries in the United States use this as the upper level for workplaces, and then have a reference level of 2.7 for homes. So there's where you can get just search WHO guidebook radon, and that will come up. So just I want to end here just briefly talking about outreach. And over 20, 30 years, there's a lot of activities I took and others that are concerned about reducing the risk of radon to try to get to the public, to increase testing, to increase, once they do test, mitigation as needed. And there's a lot of different ways to approach this, and this is just sort of a social approach, networking approach, to try to figure out how to get the public. And recently I've been working with different associations, the cancer consortiums, Council of Radiation Control Program directors, to try to educate medical practitioners, to try to get them to ask patients when they come in, how much do you smoke? Have you tested your home for radon? So that's been a real effort, but there's been a lot of efforts through these different other associations and ways to help educate the public. One of the wonderful things with working with the Cancer Consortium here in Iowa is their support for radon education. And if you go to their webpage, they have a wonderful webpage for lung cancer and specifically for radon. And this is, just go to Breathing Easier or go to the Cancer Consortium and look up their radon webpage. And almost all the papers that I talked about today and mentioned today are all at the site. There's also a wonderful video linked to this guideline that I pulled a lot of the different charts from and figures from are included. You get a link there at the website. And there's also a great video there that the Cancer Consortium helped fund a few years ago that focused on our good friend Gail Orcutt that passed away. She was a radon warrior that she helped produce with a physician at the University of Iowa that never smoked and developed radon-induced lung cancer. So one of the highlights, if you search EPA radon and health, this is what you find on that radon page for the EPA. So it talks about the University of Iowa Cancer Consortium have prepared Breathing Easier to help educate physicians. Talks about Dr. Lynch narrated the video for healthcare providers. We have the guideline for healthcare providers, but this shows the EPA's appreciation for the work that's been done by the Cancer Consortium, that this is their main radon and health webpage and has all this information that focuses or directs everyone back to the Cancer Consortium. And this is, if you go to the Cancer Consortium, this is what you'll see on the Breathing Easier webpage. And we recently lost Gail, which sometimes it's hard for me to believe she's still not with us, but she was a real radon warrior wonderful educator about radon, the school teacher that had exposures during the workplace, during her day in the workplace. So just a real motivation to myself and others to keep up the fight to reduce radon exposures. So this is the end of my presentation, but I always view the end as sort of the beginning. So if anyone is on the webinar that is interested in radon that would like to connect with me, please do. If there's any time you need slides for a presentation, please connect with me. Or if there's anything I can do in your cancer awareness efforts in the future, please feel free to contact me. And I thank you for your attention this morning. Or I guess it's not this morning, it's lunchtime now, past lunchtime. So thanks again.
Thank you, Dr. Field. And I certainly have been one person that have taken advantage of your time for assisting on some projects with that as well. So I really appreciate that. I would just like to state, if you have any questions, feel free to put them into the chat at this time, or if you want to use the reaction emojis down there and raise your hand, you can ask questions at this time as well. That will open that up. I think I see that Liz Orton actually posted one question already. She had, what can be done to reduce outdoor radon exposure? Or is it a low priority compared to indoor exposure?
Yeah, so I think the question was, what can be done to reduce outdoor?
Yes.
Is that right? Not a whole lot. There really can't be, unfortunately. But it is, in Iowa especially, it's a much lower risk than what we see indoor exposures. If your house is mitigated, very often the concentration can be lower, say up in your bedroom, than it is outdoors. So, you know, we've had a lot of studies done. I get a lot of calls. I don't understand it, Bill. My house is mitigated. I open my window and the radon goes up. Well, they're in areas where there's very high concentrations. So it was actually coming to home. So there's times if you mitigate your home, it could be lower inside. But I don't think it's a problem just in Iowa. I think it's a problem outside Iowa, but people just haven't taken the time to do the extensive measurements that we have in Iowa.
Well, I was actually interested in the one map that you showed where they have mapped the outdoor exposure rates here in the state and as well as Minnesota. Is there any signage out there where the public would know that there's higher levels out in those areas, or is it just we know it's there and
we know it's there and it's just one of those background risks that we live with all the time. And that's why we have, you know, a greater percentage of radon-induced lung cancers in the state. It's because our exposure is so much higher here. So, you know, reducing what we have control over, I think, is the best that we can do right now, is reduce indoor concentrations. That's the goal.
We have one more question here in the chat from Maria Steele. She was asking, when was the initial Iowa radon study done? And is there another follow-up study in the works? Yeah,
we did the original study back we started back in 1980 and finished it in 1990. And the study was really interesting because it was the only study done in the United States that wasn't controlled by the funding agency. We were funded by National Institute of Environmental Health Sciences. Chuck Lynch was the primary investigator for the study. In fact, I was just finishing up my PhD when that study started. And then I became the study coordinator for the study. It really helped launch my career in radon and got me interested in radon. So that was back in the early 90s. And we had the benefit of following all the other studies that had been published. And we could look at what they did. And then we could say, how can we improve on all the studies that have been done so far? And one of the wonderful things about doing the study in Iowa is, if you can imagine all the other studies, they tried to go back the past 25, 30 years for an individual who lived in their house. Well, when you try to do that in New Jersey, it's pretty tough. They have to go back maybe 6 houses and you may be missing a house, so you have to impute that data. What was so nice about Iowa, we had very unusual criteria that to be in the study, you had to live in your current home for at least 20 years. And the average that someone lived in their home for the radon study was 32 years. We had someone that lived in their house for 70 years. So we were able not to have to impute any data going back for well over 20 years in most cases. So that helped increase the rigor of the Iowa study. Plus, we didn't just say you had to live in your home. We collected where they spent time. The reason we did the outside study was we thought we could just ignore outdoor exposures, but we then had to calculate how much time people spent in their home. Where were they outside their home, outside the state? So we linked the radon concentrations to their mobility to come up with an overall cumulative exposure estimate. And we saw that if you don't use that method, it reduces the risk, the estimates for studies. So if we had done the Iowa study, like a lot of the other pooled studies did their study, they'd had a lower risk estimate because they had increased exposure misclassification. So it was a wonderful study, and you could probably only do a study like in Iowa where people tend to stay in the same houses for a long time.
I think I was amazed by that study. I didn't realize that you could actually then go back and measure the amount of radon exposure from the window panes where
Yeah,
and get that
that was an
precision as
extension
well.
of the study, right? So we developed a radon detector because we wanted to test it out, because the problem I was talking about in some studies, you have to estimate what it is if you can't back to a home. I mean, can you imagine going back to a home and saying, why do you, and the person there saying, why do you want to do a study of my home? And you say, well, someone that used to live here developed lung cancer. So we developed the radon detector. As radon decays, these little solid particles played out and they get entrapped, engulfed in the glass matrix. So if you know the environment around that piece of glass, you can measure the radon decay products in the piece of glass. So if you had a picture frame from a child when they were first born, we can tell you what that glass has been exposed to, no matter if it's been in 6 homes. So we haven't continued that study at all. But what we are doing now is, we're looking at other adverse outcomes related to radon. We think we have, a pretty good idea what the risk estimates are for radon. We need to update BEER 6 and have a consensus to look at all the data that we have and come up with more refined risk estimates. But I think it's time now to move on and see if there's other adverse outcomes associated with radon exposure.
I think Lori has a question of asking, would CT lung screening be beneficial for those that have been exposed to high levels of radon?
What a timely question. And both agencies that came out, the agency that actually Medicare and Social Security listened to, in their guidance for low dose CT screening, they say if you're close to having a number of PAC years that make you eligible for low dose screening, if you've had a high radon exposure, you consider lowering that PAC year of exposures so that they can have it. But they actually say high. So what is a high radon exposure? They weren't explicit. So right after that guidance came out, I got swamped with calls because our information is on the EPA radon webpage saying, Bill, what's the equivalent? How many picocuries per liter equals a PAC year? Well, things like that come up through consensus agreement, through associations, through a lot of work. It's not something that anyone can just say, here's the equivalency. But what do you do if you're exposed to 1,000 picocuries per liter, like in Pennsylvania? What's the medical follow-up for that? There's no guidance right now. So I've been communicating with the folks that developed the low dose CT guidance to see if they can bring greater specificity to radon exposure and the guidance people should follow. But that's the question I get all the time. Why can't I get a low dose CT? I've had this really high exposure, or what's the equivalency? Or I've had exposures that are high. What do I need to do? Should I get x-rays? No, you don't want to get more x-rays. You already had radon exposure. So that's a question, I think, a real need of research and consideration in the future as we move on. Good question.
I think Dr. Freemel has a couple questions that are going to lead well into our next speaker as well. But he was asking, is it easy to do radon mitigation on a home? What is done? And then he had a follow-up saying, new homes builds in Iowa require radon preventive measures, or just certain counties within Iowa that require that part of it?
So it's certain counties within Iowa, certain cities, in a lot of cases. It seems to be expanding, but it's certainly not throughout the state. So that, as far as mitigation, 99% of homes can be mitigated using what they call subslab depressurization, where you just ventilate the subslab beneath the basement, and you pull the air out before it enters the home, and you vent it out through the roof. Really effective way to do it. And the nice thing about it, it's sustainable, is that once you do it, the only thing you need to do maybe in the future is replace a fan in 15, 20 years. What so many people, it's so sad, they'll develop lung cancer, then they realize they have to mitigate their home. Then they mitigate it, and then they could have mitigated it 20 years ago and then had all the benefit of having it mitigated. Or people go to sell their house and they have to get a real estate transaction, do a radon test that's high, so they fix it. They could have fixed it 20 years ago and reaped some of the benefits of having a radon system installed back then. But it's, in Iowa, it runs around $1,200, $1,300. It's a covered expense under federal spending accounts. So you use your federal spending accounts for a radon mitigation system. But compared to other costs like roof repair, it's like a modest cost, but you don't look at just the one-time cost. You average that over the number of years that will reduce your exposures. If you can look at it that way, that's very beneficial. The hardest problem with radon that I deal with is we try to get people to test. And then I work with people in a lot of different states. They test, and then they can't afford the mitigation system. That's my number one problem that I have, and I'm sure some of you have as well with dealing with radon. What do you do then? Because now they know they have high radon, so they worry about the high radon, which increases their stress overall. So you see a lot of people just opening their windows and increasing their rates. But we tried to work with several nonprofits in Iowa to find the source of funds to help folks that can't afford to fix it themselves, or at least give them a little bit of help with putting a mitigation system in. And we just haven't been that successful yet.
Well, thank you, Dr. Field, for your presentation and for this brief question and answer period. I think that there'll probably be, I don't know if we have additional follow-up after all the speakers, but I know that there's more questions that are kind of percolating into the chat as well.
Okay. Oh, feel free to contact me directly too. I really welcome it. It's just the beginning. So this is our first meeting to start a further dialogue about radon in the future. I really look forward to it.
Thank you. And I would also highlight that Rachel did post links in for like next week's national science meetings, as well as those additional resources that were highlighted in those talks. Those are there in the chat for reference as well. For our next speaker then, we'll hear from Stan Leverman. Mr. Leverman is a senior housing inspector for the city of Iowa City and has worked for the city for 19 years. On July 1st, 2021, the city of Iowa enacted a radon testing and mitigation policy for single-family, detached, and duplex rental property owners and managers. This is the first policy of its kind in Iowa, and Iowa is the state with the highest radon levels in the country. He is here today to share information on this new program. Everyone, please welcome Stan Leverman.
Thank you. Thank you for having me. Appreciate the presentation we just had from Dr. Field. Lot to digest there, especially as someone who's in charge of enforcement and putting some of these policies into place, and thinking that we're making some headway and then realizing that even our scope is limited as we move forward. So again, thanks for having me. This will probably be a little bit different scope of presentation than what we've had in the past, just because I'm coming from a completely different field. So as I said, I'm Stan Leverman. I'm the senior housing inspector for the city of Iowa City. That title is kind of weird. I do not inspect senior housing or retirement communities. It just means that I'm the managing inspector for neighborhood services. All right. So a little bit about who we are. So I'm part of a division called Iowa City Neighborhood Services. So a broad range of tasks fall within my domain. Our primary responsibility is inspecting over 20,000 rental units within the city of Iowa City. Not all of those are single family and duplex. In fact, only about 4,000 of those are single family and duplex. The rest of them are older multifamilies, newer multifamilies, many with commercial spaces on the first floor, parking on the first floor. But overall, yes, we're looking at about 20,000 rental units within the city of Iowa City. Over half of our community is rental properties. We're looking at nearly 40,000 dwelling units in Iowa City, and half of them are rental. My division is also in charge of inspecting for the Iowa City Housing Authority. The Iowa City Housing Authority has jurisdiction over all of Johnson County, half of Iowa County, half of Washington County, and there's 1,457 housing choice vouchers in place that we do inspections for. We also handle 3,000 or roughly 3,000 complaints a year related to tall grass and weeds, snow on sidewalks, trash and debris. Fortunately, Iowa City is an entitlement community, which means that CDBG and home funds come to Iowa City. And with that, one of the programs that we run is a housing rehabilitation program, which allows us to assist low to moderate homeowners with repairs to their homes or even renovations to allow them to keep and maintain safe housing. I'll discuss the Healthy Homes program a little bit later. And And then recently, the city has purchased 18 duplexes in the southeast side of Iowa City in an effort to convert former rental properties into owner occupancy. And as we're renovating those, we're trying to apply best practices as it comes to health and as it comes to energy efficiency and all the things that we preach, we're trying to put into practice in there. So that's a great opportunity for the city as well. And last but not least, I also get to handle tailgating and vendor regulations during Iowa football games. And I kind of put that in there a little bit tongue in cheek because as serious as Radon is and housing code in the city, we're not just taking care of one thing. Our responsibilities are vast, and sometimes those other duties as assigned get a lot of responsibility and a lot of time dedicated to them, and the things that we really should be concentrating on kind of get paid lip service to, and you move forward. But overall, our primary responsibility is to maintain safe housing in Iowa City and enforce the health life safety codes that we have in place. So I was talking about the Healthy Homes program. In 2016, there was a partnership with the College of Public Health, University of Iowa Hospitals and Clinic, some low housing providers within Iowa City, and then government officials. And it was part of a Robert Woods Foundation grant. And one of the things that did is kind of opened up these collaborative paths between the city and the university, which has been very helpful over time since 2016. And if I go back and look and say, how did we become one of the first cities in Iowa City to adopt a radon ordinance? Without that collaboration, many years ahead of this, I don't feel that we would have had the knowledge or the understanding of radon to have that radon ordinance passed in 2020. The education that my staff was able to receive because of increased awareness, increased relationships with the College of Public Health allowed us to kind of look at things in a different way. And while we had the same ideas of what we wanted to have happen, and we kind of looked at it from the government side or from the inspector side from a different lens, and we spoke a different language. But as we sat down in trainings and conferences with public health officials, that we both had the same idea of what needed to have happen, specifically as health and housing were so interconnected. And out of that came a program here in Iowa City where we look at families that have children who are suffering from asthma or dealing with asthma, and we look to see what conditions are existing in their housing that could be causing problems for them, from moisture to buildup of dust and debris and things that were causing these families to overuse emergency health services as they manage their asthma. So taking a different approach to it, of trying to lower health cost by eliminating some of the issues related to asthma. Again, not a lot to do with radon. Radon is part of that, but it just kind of was a change in mindset for us of looking at health and housing and the importance that our inspections did in those areas, and how we could have long-term positive outcomes for people that were that had health circumstances that were directly affected by where they were living. Iowa City, we're fairly fortunate that our housing is in good shape for the most part. There's areas that the properties strive to meet the minimum standard, and that's it. But overall, when in comparison to other areas, I'm very proud of the condition of our housing. Always work to do, but yeah. So I'd like to say that we came into the radon discussion pure, and that we had the best intentions from the start, but I can't hang my hat on that. The radon discussion resulted from the state level action in 2017, where the state removed the city's ability to regulate occupancy based on familial status. And what that did is it opened up a lot of homes to higher occupancies. And there was a lot of people that felt that these homes would become more valuable to investors, and it would be harder for families to purchase those homes. But at the same point, one of the reasons they were going to be more valuable to investors is now with those reduced or eliminated occupancy standards, we saw an increased pressure of bedrooms being added in basements and other areas that have been previously non-habitable, and there was a concern that we were going to see de facto rooming houses all over Iowa City due to the pressure from student housing. So the Iowa City's response to that was to put a rental permit cap in place. And that idea was to kind of prevent more homes from becoming rental. And at the same point, there was provisions putting in place that you couldn't have over 35% of your housing or your home's floor area as bedrooms. And the idea was that we were trying to prevent bedrooms being created in places that really weren't suited for it, or to create these unhealthy living situations where these properties really didn't function as homes, but they functioned as de facto rooming houses. And we were looking to eliminate those situations. The state came back in April of 2019 and removed that provision that says that cities could not regulate by using or adopting or enforcing rental permit caps. And we return, put a 10-month moratorium in place to kind of sort through this again. And again, all through this time, we were working on with Invest Health and these different trainings dealing with health and homes. And without that collaboration and being aware of university resources as it related to health and homes, I don't think the next step would have taken place because we didn't have the contacts of that we needed. But in January 2020, we did pass the ordinance amending the housing code to require radon testing and mitigation in Iowa City. We were fortunate at that point, and from a political standpoint, our local landlord and investor community had expected something far more draconian to be implemented. And it's also hard to argue against radon with the information that we presented to them at that time. So there was very little opposition to it at that time on the face of it. I guess I would say that behind the scenes, there's been some efforts to try to get it overturned, but we haven't seen that yet. So here's our fun reading of city ordinances. If you're having trouble sleeping at night, or if you're really a political wonk at a local level, ordinance reading is always fun. You get all your whereas statements. So we kind of spelled out here in the ordinance of why we are moving in this direction. And as I said before, I will admit at the start of it, our reasons probably weren't pure at the start, but as we did our research and understood the hazards of radon and what we were seeing in our investment properties, because we would be in neighborhoods and we would see that owner-occupied properties that would sell and remained owner-occupied would have testing done and mitigation done, but when investment properties would sell, that testing was not happening, and definitely mitigation was not happening. And as I did some research, I found that it can happen in a real estate transaction. You can require it, but it's easily waived, and especially in these investment properties, there just wasn't the will of the investor to invest that time or those resources into having the properties tested. So this is the first part of the ordinance where we spelled out why we needed it to take place. And again, we were talking about healthy neighborhoods and safety. And again, as public health, you would see that, yes, we wanted to prevent people from living in homes that were experiencing high levels of radiation, and especially we're looking to avoid those situations where bedrooms especially were in basements or being added to basements where no testing had been done. Second part of it is kind of the enforcement language. So in government, a lot of good government comes from copying someone else. You find who has written the best ordinance and you take and learn from them. So coming into this as being the first one in the state, there's many things to consider. Obviously you want it tested, you know, what dwellings are you looking to have tested? What certifications are you going to accept? Obviously, the levels had been set for a while and generally accepted in the real estate community. That was easy. Retesting, again, the 8 years for the retesting and the 4 years if there was a bedroom in the basement, not based in science. It was basically said, I think we can tolerate this on a political level and we can stand behind that. This was passed initially in January of 2020. It was passed before the legislators went back into session and the moratorium was removed. Timing of that was even kind of political to kind of give people a chance to say, hey, we had the moratorium in place, we did our research and we're moving forward. So it's interesting how all of those kind of interplay with each other. And then as you read through this ordinance, you'll see that you have to make provision that yes, it's mitigated, yes, or excuse me, it was tested and it was mitigated. But like anything, you have to make determinations for what happens if this is shut off and how do we address that? So all fun things when you're writing an ordinance and you plan on enforcing. So the good news is our local city council has passed the ordinance. And there's not been any outright challenges at the state or local level, which is good. There's always a concern that when we make these changes at a local level, that the state can come in over top of us. And while we have our own housing code and have that local control of home rule, there's always a chance that the state could come in and say, this is the International Property Maintenance Code, and this is what you can enforce. If that happened, we would lose our ability to enforce this radon ordinance. The pandemic did delay us. There was quite a bit of discussion about inspections in homes while they were being occupied during the pandemic. And again, the move was made that we would delay it a year to kind of clear up some of those issues. And now starting in July, to get a new rental permit or to get the renewal of a single family or duplex rental permit, testing has to take place. And if the levels are too high, mitigation has to take place. And by August 31st of 2023, all single family duplex rentals units in Iowa City will have been tested for radon. We're giving people 30 to 60 days after that to mitigate. So if some of those tail enders are higher, the mitigation will take place a couple months following that. So it takes a little time to work through all that. We felt that was important to spread those out. So moving forward, if there's other entities that we're looking to pass radon ordinances, these are just some of my notes and some of the best practices, especially as we deal with rentals. You need to have an established rental inspection program. And in Iowa, if you have over 15,000 in population in a city, you're required to have a rental inspection program. And I think a rental inspection program and an established rental inspection program is different. Dr. Field kind of alluded to that, of different municipalities and enforce radon rules in Iowa. And that really shouldn't be the case because, well, there's ways to get around it. I understand how they're doing it, but the current building code requires Iowa to have a passive radon system installed in any new construction. The problem is as you get into outlying areas you're relying on the good faith of the inspectors to verify that is actually taking place, that they're enforcing that provision of the code, or they haven't amended that portion of the code out of it because they don't feel it's necessary. And again, for it to work in a rental program, you have to have the enforcement of it. It's not a situation where investors are going to do the right thing. They may at a certain level, but overall, we did not see that in Iowa City, that investors and owners of investment property were taking care of this and addressing the radon testing or mitigation in the properties. With anything, it's important to work with those that are going to be involved with you. We started out early discussing it with local radon testers and mitigation contractors, and we're able to establish early on that they had the capacity to handle the increased workload. Because that was one of the first things that investment property owners hit back at us, that there was no way that this could be done, that adding all these properties to the role would just throw a wrench into everything, and nothing would get done. And by taking that out of the equation early on, it really helped us to, and it kind of allowed us to show that we were working in good faith and had reasonable expectations, and had a plan forward to get all of these properties tested and mitigated as needed. And again, that adequate time to, or lead time to allow properties to come into compliance. It's a serious issue, and at the same time, you have to give people a little time to digest it and come up with ways to cover that expense. There were certain landlords that it was an issue as far as that cost, not the testing, but the mitigation. There was concerns about that. But because of how we built it into the system, we eliminated a lot of those economic complaints as well. One thing that if I was rewriting the ordinance, this is one thing that I would add. I would require the testing to be completed by an independent third-party radon measurement specialist. And I would require the mitigation to be done by an independent third-party radon mitigation specialist. It's a very nuanced part of it, but I think it goes to credibility in the program. The state of Iowa, their requirements for mitigation specialist and measurement specialist doesn't require that third party hands-off or arm's length transaction. So we are seeing a couple local property owner or property management firms hire or train some of their own staff to complete these tasks. And how our ordinance is written, I don't have the authority to say that I have to allow it because of how our ordinance is written. If they were part of any radon measurement specialist trade organization, most of those prohibit that sort of activity, but as long as they remain independent and working for one company and not being part of an association, I have to allow it. With anything, you know, I realize that with 20,000 rental units in the city of Iowa City, that I have only ensured that 4,000 of them are being inspected for radon. And I think it's important that we take that win and we work forward through this over the next 2 years, and we see what the next years bring. As the tests are coming in and as people are seeing that it's not that great of hardship, I think we'll have greater success in the future of going after and increasing the inspection rate of other properties within the rental market. That's my contact information. If there's anyone that is working with local jurisdictions that are interested in pursuing radon ordinances, I'd be happy to discuss with them what we've seen and strategies to use to convince local government officials to adopt these ordinances. And I'll see if there's any questions.
Thank you, Sam, for your presentation. We already have several questions in the chat that I'll start off with. And I just wanted to encourage anyone else to, if you have additional questions, to start adding them in there or raising your hand if you'd like to have them asked directly on that part of it. So I think the first question, you kind of hinted at this already, but I think I'll just revisit it since it was in the chat. Julie asked, are there enough local radon measurement specialists to handle all these new testing requirements? And you already kind of partially answered that, but I didn't know if you wanted to more directly speak to it.
Yeah, and they're the same testers and mitigators that handle any real estate transaction. So it was a busy year in Iowa City as far as real estate sales, and we haven't had any issues whatsoever with testing. We've had some of the companies purchase additional machines. It's a pretty simple test, honestly. It's more of having the equipment and knowing that there was an increased market. There were definitely companies that took advantage of that and made sure that other property managers and investors were aware that they had the capability of doing it. It hasn't been a problem yet.
Well, I think kind of related to that, Maria Steele was just asking for clarification about, she was wanting to understand why weren't radon test kits from like the local hardware store able to be used, since I think you kind of started touching on that as well.
Yeah, I mean, it comes down to having confidence in the results, and I'll tread lightly here, but when there's a financial interest involved, I don't want a mitigation specialist or a testing specialist has the training, understands where it needs to be placed, and should have some ethical duty to conduct it in a proper way. I'm concerned that if you took the test from the local hardware store and we accepted those, that we would have those sitting on the second floor in the attic. And I think it's important that as we're dealing with people who aren't, these are rental properties. So we want to have some confidence that the test was performed appropriately.
And then Liz asked, in the first 3 months of the program, can you give us a ballpark of how many elevated radon levels have been found, and have the mitigation process for those already started?
I can't give you those numbers. So as any good manager, I have allowed my inspectors to handle those, and that's been handled very well, but I don't have the numbers yet as far as how many elevated tests we've had. Anecdotally, I don't think we've had as many as we thought we were going to have.
Okay.
But I don't have exact numbers on those.
Well, I guess I was kind of interested too when you started to kind of present the kind of like the history building up to when the ordinance was starting to be developed. I mean, if the rental units were kind of basically at the leisure of property managers doing it, well, what do you know, what was the frequency that testing and mitigation was actually done before it was required then? I mean, was that something that you tracked and monitored, or was it basically just regular reporting?
Yeah, it wasn't part of our housing code, so we weren't tracking it at all. But anecdotally, I mean, we would go to neighborhoods and you'd see, every other house with a radon mitigation system, but you would pull up to the investment property and it wasn't there. And it just, I realize that radon levels can be different in different houses, but at a certain point, you start wondering.
And then just for clarification too, I know in some states, that in Iowa City, it was just the property owner would make the decision to have the testing done, and if they wanted to before this. But in some states, it was that if a rental unit had the person that was doing the renting would specifically have to make a specific request that the owner test, and that was the only way to get the radon testing that way. But we didn't have any of that sort of overlay here in Iowa.
There's no provision of that in our housing code or even at the state level. Definitely not at the state level.
And so if a renter wanted to know, basically they would have to do the testing themselves prior to this.
Correct.
And then there was no follow-up. Then there was no requirement that if they found something that mitigation would have to be done, that basically would have to move if they didn't like it.
Correct. Yep.
Okay. I think then we have one more question about, have you heard from other cities in Iowa looking to implement a program like this?
I've had some conversations with Dubuque, but other than that, no.
And then Maria had a follow-up question about just understanding the process about, so understanding our inspectors, do they go back to make sure mitigation systems were actually installed, or where does the follow-up occur to make sure the mitigation is actually doing?
Yeah, good question. So the testing is done by a third party because our inspectors are not certified radon testers. So we get the third party test. If it's above the limit, we require it to be mitigated, and then we document and we go back and verify that the mitigation system has been put in place.
And I think that hits all of our questions related to this part on that part of it. I guess I just wanted to really emphasize that what really impressed me the most about this regulation and the way the ordinance was set up is that frequently rental units are just an important piece of the health equity that essentially they're always forgotten about. And we know that like homeowners will go and possibly do the mitigation and testing themselves because they're invested in their own home. But
Right.
just from that point of equity issues, I think it's a really important step that Iowa City has taken forward. So I hope that it starts to diffuse out into the other areas that can start to follow this piece on that part. Okay, so thank you, Stan, for your presentation. Our next speaker then is that we're going to be moving on and discussing Iowa legislation update for radon updates, and we'll be hearing from Julie Weishar. Julie's professional background mixes together Iowa and Iowa State, urban and rural, and energy and radon. After 15 years as an Iowa educator, she launched a new statewide nonprofit organization called Energy Association of Iowa Schools, or known by EAIS, its acronym EASE, and that began in 2011. In 2015, she created and launched the School Radon Training and Support System. In 2020, Julie wrote and EASE was awarded a grant from the Iowa Energy Center to help member schools with training and certification of building operators and students. And radon will be part of this training too. Her most recent mix was organizing a collaborative between nonprofit and business experts to help schools make long-term indoor air quality improvements with their one-time elementary and secondary school emergency relief fund dollars. Welcome, Julie.
Thank you. Thanks for the opportunity to be here. It's been great to listen to Dr. Field and listen to Stan. And now I'm going to be wrapping up with some Iowa radon legislation as related to schools. So we'll be sharing some information that has been gained from some years of working with schools and radon. So following the session, you will be able to, in 10 minutes, my husband and I have a bet. He doesn't think I can finish in 10 minutes because I have so much to talk about with this, but I will, I promise. You'll be able to discuss the Orcutt School Radon Safety Bill, which is House File 243, and then explain the importance of radon testing in Iowa schools. So just so you know, all of the photos I'm sharing are real Iowa people, the real Iowa school people in real life. This is Michelle and Hal from Nashua Plainfield Schools. This is from our school radon training and support system. So we've got some more boots on the ground here talking about schools and radon. And we have this fun radon fighters wrestling belt that we use to try to make this a little bit more fun, because as you know, radon's kind of a heavy topic, so we like to do that. So you heard Dr. Field talk about Gail Orcutt, my friend Gail, we know is here with us in spirit, and as he mentioned, if you never had the honor of meeting her, she was an Iowa teacher for 33 years. And a radon advocate for over 10 years until she passed away in May of 2020. Gail is actually the person who introduced me to the Iowa Cancer Consortium, so I will forever be grateful for that as well. This is her and her daughter, Ariana. And so House File 243 actually, to my knowledge, has not officially been changed to the name the Orcutt School Radon Safety Bill, but that is our goal because we feel like it has a much better chance of passing, of getting through when you have that personal connection. So, so we're gonna just think positively and call it that. But basically, what's in it? Pretty simple. It requires all public school districts to test all attendance centers for radon once every 5 years. If necessary, it does require mitigation. fix it if you find it. The timeline in the first year of the biennial last year was by 2026 to have all school buildings tested. That will probably be pushed out to 2027 if that is passed this year, to give it that 5 years in terms of time to get things moving forward. And then at least once every 5 years after. So just in a nutshell, that's what's in it. So what I do want to point out is that this bill preserves schools' ability to test their buildings for radon themselves if they've been appropriately trained. This is very different than the rental situation that Stan talked about. Schools own and occupy their own buildings. They're not selling their buildings. They have no, financial gain for that. And they have, this is really important, they already have professionals on staff to run their buildings, and they know their buildings better than anyone. And communication is so key in radon testing that the school superintendent and others that we have involved in that radon team are just really important to be involved. This photo is actually in Coralville and right across from the Cancer Consortium. And we have schools from Oskaloosa, Washington, schools, Clinton, Davis County, lots of schools that we trained so that they would be appropriately trained to be able to test themselves. And we've had amazing success with that. So full disclosure, of course, passing House Bill 243 would be good for us. It would cause our program to grow. It would be good for all professional school radon testers, because it also that a school can decide to hire someone externally to do it as well. We don't care. We just want the testing to happen. So right now, we know the reason I'd asked that question about local measurement specialists in Iowa City is we know we do not have enough statewide folks that know how to test for schools for radon at schools to handle all of the testing that would need to be done. So we have talked to the state about that. We know we need more trained. It's a different process than home testing. So full disclosure with that, but the other full disclosure piece is obviously it's going to be great for everyone's lungs. And so we obviously support that happening. And then in the introduction, it mentioned that we did receive some grant dollars that we're very grateful for from the Iowa Cancer Consortium. That enabled us to help get this program off the ground, provided some matching grant funding for the schools to kind of be that carrot out there so that they had a reason to prioritize this, even though it's not required. And so that enabled us to gather all of this super amazing data that I am going to be sharing with you in a second. So the importance of House Bill 243. Obviously, after you've heard everything today, and you probably already knew this, one, radon causes lung cancer. Radon is naturally occurring outdoors, I will add, after Dr. Field's comment with that, everywhere, including in Iowa schools. And radon is easy, elevations are easy to fix. One thing that you also saw in one of Dr. Field's slides is schools are not the most likely place you will find elevated radon. And we know that people are more apt to be exposed to that at home because they spend more time there and ventilation systems are not as good. But we figure that Iowa schools are a good place to start. So how do we know that radon is in schools? With our program, 53 school districts across 6 years have tested 213 buildings, and that is voluntary. 36% of those had an initial elevation and they needed retested and or some corrective radon measures. There are ways to fix radon with ventilation and some other things, but 15% of those did need active mitigation. So when you first hear 15%, it doesn't sound like a lot, but then when you look at the number, that's actually 32 school buildings. So would you really want your student, or would you want to teach in a building that was elevated? And I know that answer is no. So here we have some students from Central Decatur schools getting ready to, they're tracking their radon test kit before they're putting that up. Dr. Field had this already in his presentation, so I won't spend too much time on it. But as we know, lung cancer causes the most deaths. We don't want any cancer in the world, of course, but of all types, it causes the most death. Gail actually had a Iowa lawmaker tell her at one point that prevention wasn't all that important anymore because we're getting so good at treating cancer. Obviously, someone that has not been through cancer treatment, and that was just a horrible thing to say. But this is proof here. It doesn't matter how good we get at actually helping people with cancer and treating cancer. We don't want anybody to go through that. So let's just prevent it. So this bill would cost very little to implement. That's always the next thing that lawmakers say. We don't have the money, schools don't have the money. This is Josh at Sydney Schools in the southwest, corner of Iowa by his radon mitigation pipe. The example cost, so for our training and support system, it depends on school size because it's based on enrollment. We do the training, they have a plan, we provide follow-up assistance with them. It's between $1,900 and $2,900 a year. School budgets are in the millions. That amount is not going to hurt them, plus $7 test kits. The average mitigation costs over the 6 completed years of our program have only been $3,300. It does cost more usually to mitigate than a home because schools are bigger, and so you'll have more pipe in order to reach outside, or your roof is insured for a certain amount, and you have to hire people to come in and do special things with the roof, things like that. But still, $3,300 is not a lot, and obviously worth it. So perspective of that, Gail had shared with me that the cost of 1 month of her chemo would have paid for 7 mitigation systems. So, that would last a lifetime, as Bill was talking about, to prevent lung cancer for a lifetime. So to quote her, radon safety is a necessity. It's like tornado drills, fire drills, active shooter drills. It's just a part of keeping our kids safe. It's that internal threat. Up until now, we've been focused on the external threat. This bill would prevent over 500,000 students in Iowa from being exposed to elevated radon for 12+ years in our public school buildings. And obviously there are some staff that are in our school spaces for over 30 years. And so if you happen to be in spaces, that are elevated, that's a lot to be breathing with that cumulative exposure. So in summary, in support of House Bill 243, radon's naturally occurring everywhere outside, including schools, and it's easy to fix. Public school testing, schools testing for and fixing mitigation would prevent lung cancer. It would cost very little to implement, yet it would save many lives. And as Gail said, and as my t-shirt says, fixing radon is easy, but lung cancer is not. And again, all this talk of radon is heavy, and Gail always had a sense of humor and just the very best smile. I have just a really short clip of her that I'd like to wrap up with for some fun from an interview we had at the Botanical Center in 2019 before we wrap up. I'll turn this up here. A lot of it's silent, but we're rolling. Okay.
Okay, so now what was I going to say? They learn about dupes and what all those other things are.
So that is the mix.
That's outside. Yeah. Hello.
We were competing with a weed eater. But Gail, we will continue to be radon warriors by educating our friends, our healthcare workers, and of course, lawmakers on how to prevent radon-induced lung cancer. Thanks for teaching us. Of course, our #1 goal in my talk today is our 2021 Iowa Legislative Action Plan of passing House File 243. So with that great smile, we'll close out here. So the Orcutt school radon safety bill, which we hope we get to officially call that House Bill 243, would prevent lung cancer and save lives. And so let's finish the work that Gail began to help prevent others from experiencing radon-induced lung cancer. Here we do have some students in Red Rockford Marble Rock schools. This is their radon pipe behind them that is preventing, that's venting the radon up into over the school. And I love this kid. That's bananas. I just loved looking at these kids. And then here's a picture of Gail and Dr. Field and myself at one of our Iowa Cancer Consortium's other in-person that we'll get back to someday, fall conferences at the end there. And there's my contact info. So with that, I don't know if I hit my 10 minutes or not, but after that rough start, I think we got through.
It was a very wonderful way to end today's speakerships on that part of it. I guess I would just like to say, if anyone has any questions for Julie, please put them in the chat, or if you want to raise your hand to ask them right now, we can move forward. I think that otherwise, I would just like to thank all of the speakers today. And it's been so informative, and there's been so many ideas generated forward. It's just great incentive to move forward on that part of it. And so I think that what we'll do now is I'm going to transfer the microphone back over to Liz Orton for the ending with the Meet the People segment here. And if there's any follow-up questions, that I think we can just answer them there within the chat too, for follow-up on that part of it. So thank you again to all of our speakers this afternoon.
Thank you, Tammy. All right, well, I'm gonna introduce, we have 3 different consortium members who are gonna be sharing this afternoon for us. So first up is Audrey Tron-Lam, and Audrey, you should be a co-host if you have any slides to share. Otherwise, we'll spotlight your video.
Great, thank you, Liz. And I have no slides to share, so you'll have to stare at me for a little bit, I'm afraid. My name is Audrey Tron-Lam. I am the Environmental Health Program Manager at the University of Northern Iowa Center for Energy and Environmental Education. And I guess I'm a person that you get to meet this afternoon. I recognize a few names in the participant window here, but I don't know a lot of you, so I'm really happy to introduce myself today. I think it was probably due to the brilliance of the summit organizers that I was placed on the Environmental Health Radon Day, because I dabble mostly in environmental health. And Dr. Field, I don't know if you know this, but you are my indoor air quality spirit animal when I am lucky enough to do that work in my job at the center. So after graduating from the University of Iowa's College of Public Health in 2017, I have been working to reduce toxic exposures in the environment, particularly for child health, and even more specifically, prevention of cancer in children. I work primarily with reducing unnecessary application of pesticides in both an urban and rural environment. And in the urban environment is particularly on turf and in school buildings. I work with parks, childcare centers through our program called Good Neighbor Iowa. It's a very, very accessible resource for anyone who is interested in reducing just environmental toxins in their environment and improving child health, as well as urban water quality, pollinator habitat, and just reducing toxic burden in our watersheds. I also manage another statewide public health education program called Farming for Public Health, which expands on the toxic exposures just a little bit more and looks more at the agricultural exposures, or applications, I should say, of pesticides, including herbicides, insecticides, and fungicides across the state. Farms across Iowa apply roughly 50 million pounds of active ingredient of herbicide annually. And many of these herbicides that are being used in such large ubiquitous quantities do have carcinogenic effects on humans. And so we're taking this preventative upstream approach to cancer prevention here at the center. We don't directly work in cancer screenings or that type of prevention that I think a lot of us think of. We really are trying to apply that public health mindset of turning off the faucet before you have to mop up the floor, right? Really prioritizing those upstream solutions to see where we can remove those toxic exposures in the environment. In my past life, I was a home energy auditor and am now Healthy Home certified from the Building Performance Institute. And so building science, radon are all part of the tools that I have in my tool belt when I get to work across the state. So I also do a little bit of work with schools, K through 12 schools across the state, trying to reduce indoor air quality issues such as radon, but also indoor pesticide applications, safer material selections, VOC reductions, et cetera. So we do some consulting there as well. Other than that, I enjoy knitting and playing the violin. And so that's a little spotlight on me. It's a pleasure to get to know some of you through this summit this week. And if you have any questions about the work that we do at the CEEE, please reach out at any time. I'm really happy to engage offline with any members of the Cancer Consortium. So thank you very much.
Thanks, Audrey. All right, next up we have Lori Pedig. So Lori, take it away.
Hello, thank you, Liz, for the introduction. And I am so excited to have the opportunity to just speak today about who I am and what we are over here in Carroll, Iowa. In June of 2020, I was given the opportunity to take on the role as our new cancer service director here at St. Anthony Regional Hospital. When taking this position, I looked forward to bringing our cancer service line together into a new center in the middle of a pandemic and was tasked with growth and expansion of this service line. This was going to take a team outside of what we had internally, but I was looking forward to finding new resources. And by chance, I had an opportunity call with the Iowa Cancer Consortium team when I was working on a grant. And that call sent me down such an amazing path. I was so grateful for their support and guidance, undertaking and knowing what impacts not only our region and our state, but everybody as a whole and who we are looking to serve. That information and data was able to they provided me was just really priceless. And I have felt that in the time that I've been interacting, they were able to give me the tools to be more successful as a leader and more successful for the people that we serve. There's that old saying that information is power, and that's how we make changes. And I think it's really key that people know who are members of the Iowa Cancer Consortium that they have a wealth of information and data, and all you have to do is ask for those resources, and they are overly willing to help get you what you need. Cancer control in our region is very important to me because my efforts and the efforts of my team directly impact our friends and family. We are a small community. We're very close knit, and what we do makes a real impact. And communities like Carroll already have tools to be successful. And I now want to be a constant voice for our region to make people know that West Central Iowa has got a tool, and it's got leaders, and it's got care and everything that our patients are going to need close to home. I've got two partnership stories, which I really love to share. And one is I was on our daycare board here in Carroll for 9 years. I still have children in the center, and we talked a lot about how other centers came up with gallons of sunscreen and never knew how to get access to those gallons of sunscreen. And it wasn't until I became a member this last year of the Iowa Cancer Consortium that I found out how to get sunscreen. So I was able to partner with our local daycare center and our local dermatology clinic and provide education and help write a grant to offer sunscreen to our daycare center. And we were able to get 2 gallons. They used it all summer long, and we're very thankful. And my next partnership is going to be on the rural community grant that's going to be working towards bringing and bridging the gap between COC accreditation for centers like myself and trying to meet those standards. So I'm looking forward to what that brings to us as a community and our cancer center as a whole. And I'm very thankful for the team and group of individuals that I work with here in Carroll that are so passionate for cancer care and those that we care for.
Thank you, Lori. And then our last member today that we'll hear from is Emma Hester. So take it away, Emma.
Hi, everyone. As I understand it, I think I'm the last person speaking today. So I will try and keep it brief, but I do appreciate the consortium for reaching out to me to speak today. It's been great to get to know everybody a little bit through this little Meet the People segment so far. So about me, I am the current Stacy Seifert Health Policy Fellow for UAHC. I just graduated with my MPH in May, so I've only been in this role for a couple of months, but it's been very exciting so far. My job's really interesting because I never really know what each week will look like for me, from meeting with legislators and providers to attending meetings like these. I definitely cover a wide range of topics. One of my favorite things about being in this field is just like the collaborative nature of public health as a whole, and just how passionate everyone from other specialties is about the field, and of course about their own particular focus areas. I find it really inspiring to listen to different individuals just talk about their own areas of expertise. Like today, it's been incredible to just hear from all the experts in this area. For me, one of the areas of public health I'm most passionate about is maternal and child health. Prior to coming into the role I am in now, I worked as a nursing assistant in the neonatal ICU. I volunteered at Upstream Clinic with high-risk mothers, and I also completed my practicum with the child health specialty clinics. And then right now in my job, I am doing some work on best practice legislation related to maternal health and fetal care. So I just really enjoy it whenever I get the chance to work on anything related to maternal and child health. I find it to be a very rewarding topic. And I was asked about some books that have had a big impact on me. So I decided, I'm actually working from home today for once. So I decided I would bring them out as some little props. So the first one I have is a public health book. It's The Price We Pay by Marty Macri. And I think this book is just such an important read for anybody that interacts with the healthcare system at all. Not even like, you don't even have to be a professional in the field. It really doesn't hesitate to discuss some of the glaring flaws in our nation's healthcare system, and it covers such a wide range of topics. And this book had such a big impact on me in the way that it really just like lit a fire under me to try and make a change. I read this near the end of my master's education, and I was like, it just really inspired me to take some time to think about how I can actually make an impact on some of these issues like price transparency and surprise billing in the work that I do. And then I also decided, just for fun, to throw in a recreational book as well. This is the book I'm reading right now. It's The Poppy War by Rebecca Kwong. And I threw this in because I am just so excited to finally be done with my education and be able to read for fun again. So if you're looking for a fun fictional read, that's a good one to check out. And finally, one thing that I wanted to talk about that's really important to me is just consistently working to address racial and socioeconomic disparities in healthcare. I think we've made a lot of progress in this area as of late, but there's just still so much to do. And it really impacts nearly every aspect of healthcare in our nation. And I think all of us in public health have a responsibility to focus on making healthcare as equitable as possible. So I couldn't leave today without throwing that in there at the end. But that's all I have. So thank you so much.
Thank you, Emma. All right, well, thank you everybody who participated in today's sessions. You can check the chat for information about evaluations. They'll be emailed out at the end of this week. And we will see you tomorrow for day 4. So thank you everybody and have a great rest of your afternoon.